Once again, welcome to all our dear viewers and members of the White Army for this special epignosis national level surgery long clinical case presentation competition. This is more of a mock examination rather than a competition. We have continued version of yesterday's event. Yesterday, out of 22, 12 students have presented yesterday, and the remaining 9 students will be presenting here. We have students all over the India, across the country, from all representing all the states, presenting variety of cases. So this is going to be a good preparation as well as a revision for all the final year students before the final exams. So once again, I would like to welcome our own mentor, patron of the White Army, Professor Srinivasan sir from Coimbatore Medical College for this session. Welcome to you, sir.
Welcome.
And today's special guest, I should say, is our own, but he's very special. This event is very special because it's the first event. It's again proved that how much he's passionate about teaching, how much he's dedicated to the teaching, and how much he loves his students. It's proved once again. Yes, our Professor Guru Shantappa sir, HOD of KIMS Hubli, he has won the ASI Association of Surgeons of India elections today, which was held for last month. Today results was announced in the noon. Still, immediately he messaged me, Kishan, today let's have class at 8 o'clock. That is a commitment, sir. Dedication.
Yeah,
Hats off to you. Really, I
Thank
feel
you,
like
thank you.
touching your feet from here.
No. Thank you.
No, sir.
Thank you,
No,
Kishan.
we don't get people
Thank
like
so
you, sir.
much.
Myself, Harshvardhan Singh. I'm a final year MBBS student from Pandit Deen Upadhyay Medical, Rajkot. I am presenting the case of Mr. A, who is a 65-year-old gentleman, agriculturist by profession, and a resident of Delhi. He belongs to a lower middle class as per modified Kuppuswamy scale. He got admitted to the hospital on 28th of October with the chief complaints of discoloration of body with generalized itching since 6 months, loss of appetite and weight loss since 2 months, history of presenting illness. The patient was asymptomatic 6 months back, now presented with a yellowish discoloration of eyes and urine for the last 6 months, anorexia and weight loss for the last 2 months duration. The yellowish discoloration was gradually deepening for about 4 months, and afterwards there was diminution of yellowish discoloration for about 1 month. But for the last 1 month, the yellowish discoloration is again increasing in intensity. The patient complains of itching all over the body. Scratch marks are seen over the legs and forearm. Sleep is altered. Patient is passing clay-colored stool since the onset of yellowish discoloration of eyes and urine. History of passage of black terry stools 2 months back, which has lasted for about 7 days. Patient complains of anorexia and significant loss of weight over the last 2 months. Patient complains of a mass in the right upper half of the abdomen for the last 5 months. No history of fever with chills and rigors. No history of prodromal symptoms. No history of vomiting or hematemesis. No history of abdominal distension. No history of headache, seizure, dizziness. No history of exposure to pet dogs. No history of colicky pain. Summary. A 65-year-old gentleman presented with painless progressive jaundice, waxing and waning nature, associated with generalized itching, passage of high-colored urine, clay-colored stool with history of passage of black terry stools. He also complains of loss of appetite and significant weight loss. Past history. The patient is diagnosed to have diabetes 6 months back and is on oral medication. No history of hypertension, tuberculosis, or abdominal surgery. No history of any blood transfusion in his past. Personal history, he takes predominantly vegetarian diet, appetite is reduced, sleep is disturbed, his bowel bladder habits are normal. No history of smoking alcohol, etc. Family history. No history of liver disease or any other malignancy in any of his family members. Now coming to the examination part, the patient is prepared for the examination. The place is warm with the proper exposure of light. The examiner is standing on the right side of the patient facing the head end. The clothes are removed for the proper exposure, reassurance and relaxing the patient and explaining him the procedure. Now coming to general physical examination. Conscious, the patient is conscious, oriented, moderately built and nourished. Vital signs, afebrile, pulse rate of 80 beats per minute, blood pressure of 140/80 by 80 mm of Hg taken in the right arm in the sitting posture, respiratory rates 16 breaths per minute. The nutritional status is on the normal side. having performance status of Karnofsky score 90. Icterus present, pallor present, clubbing, edema, and generalized lymphadenopathy are absent. Scratch marks are seen over the legs and forearm. No signs of liver cell failure. Now coming to the perabdominal examination, under adequate daylight and privacy, the patient is in supine position, inspected. All quadrants move equally with respiration, umbilicus in midline, shape and contour of the abdomen normal. No localized fullness seen. No visible pulsations are seen. No dilated veins are seen. Now coming to palpation, all the inspected findings are confirmed in palpation. The hands are cleaned, nails are trimmed, and the palms are rubbed to make them warm. Now, by superficial palpation, there is no localized rise in temperature noted over all the quadrants of the abdomen. Tenderness felt over the epigastric region. Now coming to deep palpation, a well-defined globular mass of size 6 cm into 5 cm, palpable over the right hypochondric region and right bulbar region with smooth surface, well-defined margin, firm in consistency and moves with respiration. Lower and medial borders are palpable and side-to-side intrinsic mobility is noted. Liver is not palpable, no splenomegaly, no free fluid in the abdomen. On percussion, dull note over the mass present, which is continuous with the liver dullness, no shifting dullness, and liver span of 12 cm at the mid-clavicular line. Auscultation, normal bowel sound heard, no bruit or venous sum over the mass. Rectal examination normal, no supraclavicular lymph node enlargement. Other systemic examination are seen on the normal side. My provisional diagnosis. This is probably a case of obstructive jaundice due to a malignant pathology, more likely to be a periampullary carcinoma. Thank you.
Yeah, Harsha, it was a very fluent and very fast and informative presentation.
Thank you, sir.
Okay, this patient has undergone any surgery in the past in the abdomen?
No, sir. No abdominal surgeries as
In
per
the past.
his past history.
Okay. Can you put that examination slide photograph? Okay. What is that scar in the epigastrium? There is no scar?
No, sir.
Okay. That is not the scar?
No, sir. There is no scar
Okay.
present.
Okay. Okay. Fine. Fine. So at history level, what you felt? Probably this gentleman has the disease. It's all right. You can speak rather than again showing the
Okay,
slides
sir.
to cut down the time. Yeah, at
Sir,
history
yellow is
level,
dis-
what did you? Yeah.
Yellow is discoloration of the urine.
What
and
is your
eyes.
thinking at
With the
history level? What is your thinking? What is your thinking? What is the disease he has
Obstructive jaundice due to a malignant pathology
at history level?
at history level.
That description, what you have given, sometimes it was there, sometimes it was not there, and again it is. So what is that ultimately you wanted to
It
highlight?
is waxing and waning of jaundice. In
So-
case of periampullary carcinoma, it is seen that the central part gets necrosed because of the lack of blood supply, and it gets sloughed off and relieving the obstruction, and thereby the symptoms of jaundice diminish.
Okay,
And this is called waxing.
what is the other type of jaundice one will have in a malignancy? What is the other type of jaundice one can have?
Okay, medical jaundice and surgical jaundice.
No, no. If this is waxing and waning, what is the other type of jaundice in a malignant cause of obstruction? It's a persistent progressive jaundice, the other variety.
Persistent progressive jaundice seen in case of a carcinoma of head of pancreas.
Okay.
Because
Did you find out whether this gentleman has a history of fever?
no, sir. No history of fever or
What is
reflux.
What is the importance of that? What is the importance of that?
Cholangitis, to rule out to seek cholangitis.
Okay. Has he got history of melena? Your description has
Yes,
some
sir. Yes,
points.
sir. Passage of black terry stools is there.
Okay. What may be the reason for that?
Sir, the necrosed part which gets sloughed off, it is appearing in the stools. Clotted bloods are seen in the stools. That is
Any other reasoning for having blood in the GI system or blood in the stools? One is necrosis of the tumor. Any other reasons?
Yes, sir. Hematochalcia, upper GI bleeding.
Secondary to what? Secondary to what? In relation with this disease. In relation with this
portal
disease.
hypertension causing variceal bleeding.
Why portal hypertension? Why portal hypertension?
So
You're
because
right,
the
but
tumor can involve the vessels, surrounding vessels like portal vein, superior mesenteric vessels are getting
very
involved
good.
in this.
Very good. Okay. Theoretically, yes. Theoretically, yes. That can lead to portal hypertension. And if it has involved only the splenic vein and it has caused splenic enlargement and associated enlarged blood vessels there, what is that portal hypertension called? You understood the question?
Extrahepatic occlusion of vessels
No.
leading to splenic thrombosis and
What is that called? If it is only splenic vein is getting obstructed, causing splenomegaly and portal hypertension, what is that called? That type of portal hypertension.
sorry, sir, no idea.
You understood?
Yes, sir, I understood, but
You don't know the answer? Okay, fine. That is called left-sided portal hypertension. Otherwise called sinistral portal hypertension. Okay, fine. How do you proceed with this case? What you would like to do?
so first I will do the investigation for confirming my diagnosis and for staging the disease and for planning my treatment. So first of
Okay.
all, I will move to liver function test. This in serum bilirubin, I can see rise in conjugated bilirubin. Serum enzymes are raised. For example, alkaline phosphatase, GGT is raised. Albumin and globulin for the assessment of liver, and prolonged prothrombin time can be seen.
Yeah, Harsh, just you tell me two important entities in LFT which will help you for the management. Only two. Only 2
Sir,
points
serum
in
bilirubin,
LFT.
serum bilirubin, prothrombin time.
Bilirubin will be raised definitely because the patient is jaundiced. How it will help you for the management? Prothrombin time accepted because coagulation profile it will depict and it will depict the function of the liver. One more, which should matter for your treatment.
Albumin.
Albumin and prothrombin time. Okay. What other investigation you would like to do?
So after this, I will carry out a USG to delineate the anatomy and the lesion of the gallbladder, liver, pancreas, CBD. It tells us about if there is presence of any stones in the gallbladder or CBD, and in case of periampullary carcinoma or the carcinoma of head of pancreas, we can see a double duct sign, which is dilatation of the bile duct and pancreatic duct. Or
so that is made out in ultrasound itself, or you want to do some other investigation for that?
For confirming. For proceeding, we will carry out the CT scan, which is known as pancreatic protocol CT scan.
Okay, you have found out any other test where you can take a biopsy and do some investigation or to check if it is an ampullary cancer?
So endoscopic USG guided FNAC.
No, ampullary cancer. Can you see that and take a biopsy by some means? In what way you can see that lesion at the ampulla? What test will tell us? We can see the growth and take a biopsy. Endoscopy will not tell
diagnostic
us.
laparoscopy. No.
No, laparoscopy, it will be outside. No. Endoscopy
USG.
Not USG. Endoscopy itself with a lateral viewing duodenoscope or upper GI scope. You can see the tumor and take a biopsy there. Okay. What is that you want to do for this man? What is the treatment?
Sir, if it is a resectable tumor, I will go to the curative surgery. First of all, exploratory laparotomy for confirming my diagnosis, and then proceeding to Whipple's procedure, that is pancreatic duodenectomy. But first of all, I will prepare my patient for the surgery. That is, if he is anemic, hemoglobin less than 10 gram percentage, I will go for preoperative blood transfusion, and for prolonged prothrombin time, I will give parenteral administration of vitamin K for 5 to 7 days. And if it is not working, that means in case of hepatocellular dysfunction, I will give fresh frozen plasma. In case of dehydration, I will give IV fluids or normal saline. And if the person is malnourished, I will go with some parenteral nutrition or enteral nutrition And for preventing septicemia, I will give him broad spectrum antibiotics like second generation cephalosporin combining with aminoglycosides preoperatively. Then moving to the surgery, the structures which are removed in the Whipple's procedure are whole length of the duodenum is removed up to 10 centimeter, up to 10 centimeter, and distal 40 to 50% of the stomach is removed, and head and neck along with uncinate process of the pancreas is removed. Distal CBD is removed, gallbladder is removed, and associated lymph nodes like pericholedochal, peripancreatic, periduodenal lymph nodes.
What are the anastomosis? 3 anastomosis done after
Sir,
pancreaticoduodenectomy?
Pancreaticojejunectomy having end-to-end anastomosis, followed by hepaticojejunectomy having end-to-side anastomosis, and then at last I will do gastrojejunectomy.
Yeah, very good. You have understood the procedure. You have understood the disease process. Very nice. Thank you. Thank you, Harsha.
Thank you, sir. Thanks a lot.